The Blue Rhino G2 Multi-Percutaneous Tracheostomy Introducer Set is intended for percutaneous dilational tracheostomy for management of the airway in adults only. Tube placement should be performed in a controlled setting with the assistance of trained personnel. For complete instructions, contraindications, warnings, precautions, and patient preparation information, see the instructions for use that are included with the product. The Blue Rhino G2 Multi-Percutaneous Tracheostomy Introducer Set consists of an introducer needle, J-tipped wire guide, introducer dilator, guiding catheter, loading dilators, and single-staged Blue Rhino G2 multidilator. In preparation for the procedure, generously lubricate the surface of the appropriately sized loading dilator and load the tracheostomy tube onto the dilator. Ensure that the tracheostomy tube's tip fits snugly on the dilator. Ensure that the balloon is completely deflated. Thoroughly lubricate the tracheostomy tube assembly. Palpate the landmark structures, including the thyroid notch and cricoid cartilage, to ascertain the proper location for tracheostomy tube placement. Access and ultimately tube placement is ideally made at the level between the first and second tracheal cartilages or between the second and third tracheal cartilages whenever feasible. After introducing local anesthesia, make a 1.5 to 2 centimeter skin incision, either vertical or horizontal, at the chosen insertion site. If desired, use a curved mosquito clamp to gently dissect vertically and transversely down to the anterior tracheal wall. With a fingertip, dissect the front of the trachea in the midline, free of any tissues, and identify the cricoid cartilage. If needed, displace the isthmus of the thyroid downward if present. An adequate skin incision and blunt dissection of the subcutaneous tissue can minimize the need for excessive force and torque throughout the procedure. Excessive force and rotation may lead to long-term complications such as stenosis. Deflate the endotracheal tube cuff and withdraw to an appropriate distance above the insertion site, yet still within the trachea. Reinflate the cuff once the proper position of the endotracheal tube has been reached. Attach a syringe half filled with fluid to the introducer needle and seek the tracheal air column by directing the needle in the midline, posterior. Verify the entrance into the tracheal lumen via aspiration on the syringe, resulting in air bubble return. Alternatively, if using bronchoscopy, visualize the needle entering the trachea. Remove the syringe. Introduce the J-tipped wire guide several centimeters into the trachea. The wire should advance freely without resistance. If resistance is encountered, do not force the wire guide. Confirm the correct FEP sheath or introducer needle placement via bronchoscopy, then advance the wire guide into the trachea until the distal mark on the wire guide reaches skin level. Remove the FEP sheath or introducer needle while maintaining wire guide position within the tracheal lumen. Maintaining the wire guide's position at the skin level mark, dilate the initial tracheal access site by advancing the short 14 French introducer dilator over the wire guide with a slight twisting motion. Remove the dilator while maintaining wire guide position. Activate the hydrophilic coating by immersing the distal end of the Blue Rhino G2 multidilator in sterile water or saline. Advance the Blue Rhino G2 multidilator and the guiding catheter as a unit over the wire guide while maintaining wire guide position. Align the proximal end of the guiding catheter at the mark on the proximal portion of the wire guide. This will ensure that the distal end of the guiding catheter is properly positioned back on the wire guide, preventing possible trauma to the posterior tracheal wall during subsequent manipulations. Bronchoscopic guidance may also prevent possible trauma to the posterior tracheal wall. To properly align the dilator on the wire guide and guiding catheter assembly, position the proximal end of the dilator at the single positioning mark on the guiding catheter. This will ensure that the distal tip of the dilator is properly positioned at the safety ridge on the guiding catheter to prevent possible trauma to the posterior tracheal wall during introduction. While maintaining the visual reference points and positioning relationships of the wire guide, guiding catheter, and dilator, advance them as a unit to the skin level mark on the Blue Rhino G2 multidilator. Proper positioning and alignment may help minimize complications. Advance and pull back the dilating assembly several times to effectively dilate the tracheal access site. The wire guide must always lead the dilator and the guiding catheter assembly to prevent possible trauma to the posterior tracheal wall during dilation. Care should be taken to keep the guiding catheter assembly properly aligned with the mark on the proximal portion of the wire guide. This will ensure that the tip of the guiding catheter assembly does not advance beyond the distal tip of the wire guide within the trachea. Remove the blue Rhino G2 multidilator, leaving the wire guide and guiding catheter assembly in position. Respiratory air leak through the tracheostomy stoma should be noted to confirm intratracheal location of the wire guide and guiding catheter. Advance the tracheostomy tube loaded on the dilator over the wire guide and guiding catheter assembly to the safety ridge of the guiding catheter. Then advance the wire guide, guiding catheter, loading dilator, and tracheostomy tube as a unit into the trachea. The assembly should be directed perpendicular to the axis of the trachea during insertion for uniform dilation between the tracheal cartilages. Once the tracheostomy tube is within the tracheal lumen, the assembly may be directed caudate. Proper positioning and alignment may help minimize complications such as stenosis. Advance the tracheostomy tube to its flange, remove the dilator, guiding catheter, and wire guide, leaving the tracheostomy tube in place. At this point, the bronchoscope may be inserted into the tracheostomy tube to confirm correct placement. If you are using a dual cannula tracheostomy tube, insert the inner cannula at this point. Inflate the tracheostomy tube balloon cuff. Connect the tracheostomy tube to the ventilator. Confirm the position of the tracheostomy tube via standard methods such as capnography and breath sounds. Deflate and remove the endotracheal tube. Perform suction to determine if any significant bleeding or possible obstruction exists that has not been noted to this point. If necessary, one suture may be taken at the bottom of the initial incision. Follow hospital protocol for post-tracheostomy care and maintenance.